Hello, welcome to a dermatology question. Here we have a 10-month-old baby girl who was brought in by her parents because of a rash on her abdomen and cheeks. The key points in the history are that the rash is itchy, red, and scaly, and it gets worse with scratching. Sometimes the lesions are even crusted. The symptoms worsen in summer, especially after bathing. We also see an atopic background in the family. The father has allergies and paternal cousins have chronic itchy rashes. On exam, the baby has a blanching, erythematous, scaly rash on the abdomen, back, and face, but otherwise her growth and physical exam are normal. Now the question is asking us, what is the most appropriate response? At this point, you can pause the video and guess the answer yourself. Let's go through the options together. This clinical scenario is consistent with atopic dermatitis, eczema, and is very common in children. Infants with eczema typically have pruritus, erythema, and scaly, crusted lesions on the trunk. Extensor surfaces of the extremities, cheeks and scalp. Diaper areas are usually spared. The pathogenesis involves genetic defects in protein and lipids that normally act to keep the epidermis hydrated and protected. However, disruption of this barrier results in an inflammatory reaction to triggers such as excessive bathing, irritating detergents, and extreme temperatures. Management requires compulsive elimination of triggers and frequent emollients to provide a barrier and restore hydration. If emollients are inadequate, topical steroid creams ointments may be applied on the body. Low-potency steroids are preferred on the face and skin folds due to risk of skin atrophy. Choice A. Staphylococcus aureus colonization is associated with atopic dermatitis and may contribute to exacerbation by locally acting staphylococcal superantigens. Eczema is a risk factor for impetigo, honey-crusted lesions, and cellulitis, focal erythema, warmth, swelling, which require antibiotic treatment. These diagnoses are unlikely based on this patient's examination. Choice C. Eczema is a clinical diagnosis based on history and physical examination. Although serum IgE levels may be elevated, laboratory testing is not recommended or necessary to confirm the diagnosis. Choice D. Wiskott-Aldrich syndrome is an X-linked disorder associated with severe eczema, but these patients are immunocompromised and have severe bleeding from thrombocytopenia. Eczema may have a genetic basis based on twin studies, but there is no evidence that the condition alone is inherited in an X-linked pattern. Choice E. Atopic dermatitis typically clears in nearly 40% of patients by adulthood, but unlike infections, protective antibodies do not play a role in this disease process. Thanks for watching. See you in the next video.